Hello, my name is Cynthia Koo, and this lecture is focused on paravertebral blocks. This case is a 90-year-old man who presents after a fall with left-sided T4 through 6 rib fractures. He is saturating 94% on 2 liters nasal cannula and is reporting severe pain, and he is splinting on exam. The intensive care unit consults the regional team for his pain management. Which block would you perform? Because the rib fractures are unilateral and fairly localized, a paravertebral would be a great option. If the rib fractures were bilateral, an epidural could be more appropriate, or if he had rib fractures in multiple levels that would be hard to cover with an epidural or paravertebral, or if the patient were anticoagulated, an erector spinae plane block might be the more appropriate choice. During this lecture, we'll start with an introduction and discuss indications and contraindications for the block. We'll talk about the anatomy of the paravertebral space and the technique for placement using landmarks and ultrasound. And then we'll discuss the management and some data regarding the use of the paravertebral block, and finish off with a review question. The paravertebral block was first performed in 1905 and was popular in the early 1900s before falling out of favor. It was then resurrected in 1979 with the placement of paravertebral catheters. The effects are ipsilateral, meaning one-sided, segmental, they cover a few dermatomes, they're somatic, meaning they cover sensation, and sympathetic, meaning that the paravertebral block can cause hypotension. The paravertebral block is often used in thoracic surgery or breast surgery. It can be used to cover rib fractures, and it can also be used to cover cardiac or abdominal surgery. The contraindications to placement of a paravertebral block include infection of the site of placement, allergy to local anesthetics, empyema, paravertebral space occupying cancers, coagulopathy, and chest deformities. Let's review the anatomy of the paravertebral space, which is a triangular space adjacent to the spine. The boundaries are the pleura, the vertebral body, and the transverse processes and the costo-transverse ligament. The paravertebral space contains adipose tissue, intercostal nerves and vessels, the dorsal rami and rami communicantes, and the anterior sympathetic chain. The mechanism of the block involves spread to the somatic and sympathetic nerves within the paravertebral space, as well as the intercostal space laterally and epidural space medially. The coverage is unpredictable, but typically is 1 level above and 2 levels below the level where the block is placed. Because of the continuity with the epidural space, multiple small volume injections are preferred over one large injection, for example in breast surgery. Approximately 10% of the patients will have contralateral spread. In the case example with T4 through 6 rib fractures, the ribs could be counted under ultrasound to identify the correct level, and then the paravertebral could be placed at T5. Now we'll switch gears and talk about the technique for paravertebral placement. Historically, this was done using the landmark technique. The patient was placed in a sitting position, and the spinous processes were counted starting at C7. The levels were marked down midline, as well as 2.5 centimeters lateral to midline. A 22-gauge TUI was inserted until contacting the transverse process, approximately 4 centimeters in depth, and walked off until there's a loss of resistance or the needle is 1 centimeter past the transverse process. If the transverse process is not contacted, the needle is redirected cephalad and caudad. If the transverse process is still not contacted, the needle is advanced another centimeter and the process is repeated. Once the paravertebral space is identified, 20 mL of long-acting local anesthetic is injected in aliquots. In the ultrasound technique, the patient is often positioned prone. Depending on the patient's body habitus or the ultrasound being used, a linear or curvilinear probe could be used. The ribs are counted from T1 to the level of the injury or surgery. When scanning sagittally, the ribs appear round, whereas the transverse processes are square. The lamina have a flat appearance. At the level of the transverse process, the pleura and costo-transverse ligament can be seen. The needle can be inserted in plane or out of plane between the transverse processes, below the costotransverse ligament, until injection of fluid depresses the pleura. An alternative ultrasound approach starts with the ultrasound probe in the transverse position. In this figure, you can see the rib intersect with the transverse process. Superficially, there are the trapezius and erector spinae muscles. The ultrasound probe is then moved between the transverse processes for a view of the pleura. The needle is placed in plane into the paravertebral space below the intercostal muscles. For single-shot injections, up to 20 mL of 0.5 ropivacaine or bupivacaine can be used in increments. Because of the high systemic absorption, epinephrine can be added. For catheters, the dose is 0.2% ropivacaine at 0.1 to 0.2 mL per kilo per hour. The complications include block failure, vascular puncture, hypotension, pleural puncture, pneumothorax, local anesthetic systemic toxicity, and epidural, subdural, or intrathecal spread, especially if large volumes are injected or if the needle is directed medially. Signs of pleural puncture or pneumothorax include loss of resistance. The patient may cough, have sharp chest pain or shoulder pain, or sudden hyperventilation. Now we'll switch gears and talk about the comparison between paravertebral blocks and epidurals in thoracotomy patients. Thoracotomies are amongst the most painful surgeries patients can undergo, with 30 to 50% of these patients having pain up to 5 years afterwards. Acutely poor pain relief can lead to immobility and ineffective breathing and clearing of secretions, which could cause atelectasis, chest infections, and blood clots. This Cochrane review was a meta-analysis of 14 studies containing 698 patients. The study's main goal was to identify differences in 30-day mortality and major morbidity, but there were limited evidence regarding these outcomes. The secondary outcomes for the meta-analysis were pain scores, which were non-inferior in the paravertebral group compared to epidurals at all time points measured. There was insufficient data regarding chronic pain because of limited follow-up in the studies included. This figure shows the risk ratio, which less than 1 favors paravertebral and greater than 1 favors epidural. Comparing the block success rate, there's a trend towards a lower failure rate in paravertebral blocks, around 2%, compared to epidural blocks, which had a failure rate of around 11% in the studies that reported the data. The analysis of minor complications showed a lower rate of minor side effects from paravertebrals compared to epidurals, including a lower rate of hypotension, nausea and vomiting, itching, and urinary retention. There was no statistical difference in hospital length of stay. The study from 2020, done in the United Kingdom, compared regional anesthetic techniques for rib fractures at 2 tertiary centers. 354 patients were included who had received serratus anterior plain catheters, thoracic epidurals, or paravertebral catheters. They found no significant difference in pain scores between serratus plain paravertebrals and epidurals. The mean inspiratory volume increased post-block by 789 mLs. 98% had moderate to severe pain before the block, and that number decreased to 34% after the block. This breast surgery study comparing IV morphine to ESP blocks and paravertebrals showed statistically significant reduction in pain in both blocks compared to IV morphine, and no significant difference between the two techniques. This board review question is from the Hall and Chanigan book. Each of the following is a potential complication of thoracic paravertebral blocks except A. Pneumothorax, B. Epidural spread of local anesthetic, C. Hypertension, or D. Total spinal. The answer is C. Hypertension. Paravertebral blocks can rarely cause a pneumothorax or spread to the epidural space or intrathecal space. They will affect the sympathetic chain, which is more likely to cause hypotension rather than hypertension. In summary, paravertebral blocks cause unilateral, somatic, and sympathetic nerve blockade. They are used for cardiothoracic and breast surgery and for rib fractures. Compared to epidurals, paravertebrals are non-inferior in their pain control for thoracotomies and have fewer minor side effects. Check out the following references and links for more information regarding paravertebral blocks.